Greetings everyone. Today's lecture is about cleft lip and cleft palate and their management. Cleft lip and palate are congenital anomalies that affect three regions in the human body: the upper lip, the nose, and the palate. It is the second most common congenital deformity after clubfoot, and it affects 1 in every 750 live persons worldwide. Your learning objectives as an undergraduate student is to have a basic idea about the cleft lip, palate, and their development and their management. So we will talk about normal anatomy, the embryological development, and the cleft anatomy. Then we will talk about the classification, the epidemiology, and the risk factors of cleft lip and palate. Then the associated problems with the children born with cleft lip and palate, the time of management, and the non-surgical and the surgical management. By the end of this lecture, you should be able to answer some important questions as what happened intrauterine that leads to the development of cleft lip and palate? If a parent of a child with cleft lip asks you, is it possible for his child to be normal with treatment? If he asks you what happened, who has the fault? How should I feed my baby? What about my future children? You should also know some basic concepts of surgical techniques and the prognosis of the child with cleft lip and palate according to the classification mentioned. First, we will talk about the normal anatomy of the upper lip and the palate. Let's first speak about the anatomy of the lip and start by the nose. This part of the nose is called the columella of the nose, the columella, and the part that encloses the nostril is called the nasal ala, the columella, and this part called the nasal ala. And then the upper lip, we have here two ridges, longitudinal ridges called the philtral colons. These ridges called the philtral colons, and next slide we will know their origin. Their base is called the cupid's bow. It resembles a bow. We call it a cupid's bow. The red portion of the upper lip is called the vermilion. The junction between the skin and the vermilion is called the vermilion roll or the white roll. The vermilion itself is divided into two portions: a dry portion, the externally appeared dry, and a wet portion. The inner anatomy of the upper lip, we find that we have two muscles called the orbicularis oculi muscle, which is called the mouth sphincter, responsible for closure of the mouth, tight closure of the mouth, and the levator libii superioris. From its name, it assists in the upper lip elevation. The blood supply, the superior and the inferior labial arteries, the sensory innervation from the second division of the trigeminal nerve, the motor innervation from the facial nerve, the cranial nerve number 7, both the buccal and mandibular branch of this nerve. This illustration shows the orbicularis oculi muscle and its insertion. It inserts in the contralateral side and the dermis of the skin. This insertion forms the philtral colons, the two vertical ridges we speak about earlier. The left side inserts in the contralateral dermis, and the right side inserts on the contralateral dermis, forming the philtral colons. This image shows the blood supply of the upper and the lower lip. The facial artery, the main blood supply, give the inferior and the superior labial branches, supplying the lower and the upper lip respectively. There is also a branch, the infraorbital artery, from the infraorbital foramen. Anatomy of the palate. The palate has two classifications, an anatomical classification and embryological classification. The anatomical classification into a hard palate and a soft palate. The hard palate, from its name, contains a hard bone. This is the anterior part called the hard palate with no muscles. The soft palate contains no bones, but it contains the muscles of the palate. This is the soft palate. From embryological classification, this foramen called the incisive foramen. The part of the hard palate anterior to the incisive foramen called the primary palate. Everything posterior to the incisive foramen is called the secondary palate because they have a different embryological origins. The muscles of the soft palate, especially the levator villi palatini muscle, which form an arch with the contralateral part, a transverse arch. They originated from the base of the skull. Its main function, when contracted, is to close the velopharyngeal foramen. The velopharyngeal sphincter located between the oral cavity and the nasal cavity posteriorly. When it is closed during speaking by the action of the muscles of the soft palate, it results to direct all the air exiting your lung into your mouth, moving and articulating organs like your tongue, like your lips, to pronounce the consonants of the speech. So, when there is a defect in the muscles, as in cases of cleft palate, what we'll expect? We expect that the air will escape to the nose during the pronunciation of the oral consonants, resulting in what we call a hyponasality of speech, which is a major and a common problem affecting children at the age when they start speaking 2 or 3 years old, and if not corrected early by surgical intervention or other means of management of velopharyngeal incompetence, it will lead to a permanent speech problems. Here we found the muscles of the soft palate. The levator villi palatini muscles from the origin of the skull form an arch with the contralateral side. You can imagine when it contracts, it will elevate the uvula and close the velopharyngeal sphincter. This is called the velopharyngeal sphincter between the nasal cavity and the oral cavity, which is beneath it. Some other muscles, the tensor villi palatini muscle, this muscle, which has a major role in opening of the Eustachian tube. We also have the superior pharyngeal constrictor. These are the main muscles for your understanding of the basics of the cleft palate. Blood supply of the palate from the greater palatine artery, from the greater palatine foramen here, and the lesser palatine artery. Embryological development. The upper lip developed during the 4th week. The palate, the primary palate, developed from the 4th to the 7th week, and the secondary palate from the 6th to the 8th to the 9th week. It all finishes at about the 3rd month. To revise your embryological knowledge, the face developed from a 5 prominences named the frontonasal prominence, 2 maxillary prominence, and 2 mandibular prominences. The frontonasal prominence, from its name, fronto, it forms the forehead, the naso, it forms the nose. This is the frontonasal process. The maxillary prominences, it form part of the upper lip, the lateral parts of the upper lip, when they fuse with the part of the frontonasal eminence called the median nasal process. This part called the median nasal process, which is a part of the frontonasal prominence. It forms the central part of the upper lip. It unites with the maxillary prominence from both sides to form the lateral part of the upper lip. The mandibular prominences form the lower lip and the mandible. This illustration shows that process, the frontonasal process. This segment called the median nasal process. The blue color is the maxillary prominences, which unite with the median nasal process here to find the upper lip. So the upper lip is formed by the union of the maxillary processes laterally and the central part from the median nasal process. So if there is a cleft, where we will expect to find it? Yes, in these parts, the left part, the left side, or maybe bilateral cleft or unilateral cleft in this area. When we see this process from inside the mouth, we are looking now at the palate. This is the median nasal process, and these are called the palatine shelves. They are a processes of the maxillary prominences. They unite together to form the palate, and they unite anteriorly with the median nasal process, which here forms the premaxilla, to give the hard palate. This will be the incisive foramen. The part anterior to it is called the primary palate, derived completely from the median nasal process. It has a different embryological origin from the other parts of the hard palate, which came from the maxillary prominences. They unite together to form the hard palate. The rest of the palatine processes form the soft palate. So the cleft palate will have this form of a Y shape like this. It may be unilateral, it may be bilateral, it may be unilateral complete the entire length, as we will see later in the classification. This image shows the entire process. The frontonasal process gives us the median nasal process, which unite with the maxillary prominences to form the upper lip. Here is the frontal view. The lateral part of the upper lip came from the maxillary processes, and the middle part came from the median nasal process. Anteriorly, the lateral palatine shelves from the maxillary process unite with the premaxilla or the primary palate anterior to the incisive foramen to form the complete palate. This video shows us the embryological development of the cleft lip and palate. Here we find the embryo, the frontonasal process, the two maxillary processes, and the maxillary process. They will begin to unite together, the two maxillary processes with the median nasal process, to form the upper lip. Here we found the upper lip. From inside the mouth, here the two palatine shelves unite with the primary palate. After we figured out the embryological origin of the cleft, now let's see how this embryology presents itself on the anatomy. This is a child with a complete unilateral right side cleft lip. We see here that there is a discontinuity of the orbicularis oculi muscle. The fibers of the muscle are inserted vertically, not horizontally. We see a short columella deviated toward the normal side, and we see a flat ala of the nose on the abnormal side. We can also see there is a cleft alveolus. In this case, we see incomplete unilateral right side cleft lip. It is called incomplete because the orbicularis oculi muscle is continuous at the upper part of the lip, in this part which is called the seminal band, and only the cleft in the lower part. It's called incomplete cleft lip. It's also associated with a mild nasal deformity. Also in the cleft palate anatomy, we see that there is a cleft in the entire palate, extending into the primary palate, into the alveolus, and presenting itself on the lip. So this is a case of a complete unilateral left side cleft lip and complete cleft palate. This case is a bilateral cleft lip. The central part, which was derived from the medial nasal process, the bony part called the premaxilla, the soft tissue part called the prolapbium. The prolapbium does not contain any muscle fibers, unlike the cases of unilateral cleft lip, where the two sides of the cleft have muscle fibers. The prolapbium here has no muscle fibers. This information is important when you study the repair of the cleft lip. This is also a case of a severe bilateral cleft lip and cleft palate. This is called the prolapbium, as we said. This is the premaxilla. There is a white cleft of the alveolus. There is a white cleft of the two palatine bones. Here we can see the vomer, which is a nasal bone from inside the mouth. This illustration reminds us of the normal anatomy of the normal palate. If we had a cleft here dividing the entire palate, so the muscles of the soft palate will be oriented vertically, not horizontally. This will lead to a defective function. The function, as we said before, is to elevate the soft palate to close the nasopharyngeal sphincter, directing the air into the mouth, which lead to pronunciation of the oral consonants on speech. If this muscle is defective and not repaired, so the function of the soft palate is lost, so there will be a velopharyngeal incompetence or insufficiency, which is a common congenital anomaly after cases of cleft lip and palate. It has also other causes. This case, if not treated well, will lead to a permanent hyponasality of speech in these children. Again, this image shows us the normal function of the soft palate. This is the palate, the soft palate, the posterior part. Here it is a normal function where it is elevated, contacting the posterior pharyngeal wall, closing the nasopharyngeal sphincter, directing the entire air into the mouth, leading to the normal pronunciation of speech. In this case, there is a defective function of the soft palate, so the air escapes to the nose during speech, leading to hyponasality. Now, let's study the classification of the cleft lip and cleft. The Kernahan's stripped Y classification is one of the simplest ways to classify cleft lip and palate. Here we can figure it as a letter Y in the English alphabet. The 1 and 4 for the cleft lip. 1 is the right, 4 is the left. The 2 and 5 is for the cleft alveolus. Alveolus is the bone that carry the teeth in normal human. 2 and 5 for the cleft alveolus. 3 and 6 for the cleft hard palate anterior to the incisive foramen. 7 and 8 for the cleft hard palate posterior to the incisive foramen. 9 is for cleft soft palate. The affected parts here are marked in blue, and the unaffected normal parts are white. So in this case we have a bilateral cleft lip, a complete cleft alveolus on the left side, and a complete cleft palate, including the hard and the soft palate. Some cases we might find that we have only a unilateral cleft lip, a complete cleft lip on one side, including the lip, the alveolus. We could also find cases with isolated cleft palate or even isolated soft cleft palate. So again, the cases could be unilateral or bilateral. It could be complete or incomplete. The cleft palate itself could be complete, could be incomplete, isolated, meaning that there is no cleft lip with it, or syndromic, associated with syndrome. It could be combined cleft lip and palate. This image also shows the diversities of cleft lip. Here is a normal one. Here is a microform cleft lip, which is a type where there is just a notch in the vermilion. Here is a unilateral incomplete cleft lip because there is a seminar band, as we said before. Here is a unilateral complete cleft lip extending to the nose. Here is a bilateral incomplete cleft lip, and here is a bilateral complete cleft lip. The cleft palate itself, as we said, could be just only a cleft or a bifid uvula. Could be cleft of the soft palate only, or could be cleft of the entire palate, and it could be a submucous cleft where we found that the mucosa is completely intact and the cleft is in the muscles and the bone. Now let's talk about the epidemiology of cleft lip and palate. The most common cases found are combined cleft lip and palate in 46%, isolated cleft palate alone in 33%, isolated cleft lip alone in 21% of cases. Overall, the percent worldwide is 1 in every 700 live persons. There is also a racial heterogeneity found. The Africans have the lowest incidence in 0.5 every 1,000 live persons. The Asians have the highest ratio found in about 2 per 1,000 live persons, and the Caucasians in between 1 every 1,000 live persons. We also found that the unilateral left side is the most common about the cleft lip. The unilateral left cleft lip is the most common. After this is the right. After this is the bilateral in a percentage of 6 to 3 to 1. There is also a male predominance in about 2 to 1 and a syndromic association in 14% of cases. Is there a familial association? Yes. We found that if there is no family history, no parents affected, the percentage is the normal one, 0.1%, which is the 1 per 1,000 live persons. If we have an unaffected parent and a single affected sibling, this means that the second child is affected at a more percentage, about 4%. If we have two affected siblings, this means that the third one will be affected at a percentage of 9%. If one parent is affected and no affected siblings, then the children have the percentage of 4. If we have also a one affected sibling with one affected parent, the percentage rises to 17. Risk factors. Facial clefting was found to follow a multifactorial origin theory. This means that it needs a genetic susceptibility in the person and a environmental factors. If one of them is absent, the gene will not manifest itself. The environmental factors quickly can be divided into in-womb environment, external environment, nutrition and micronutrient, especially the folic acid deficiency and the drugs taken during the pregnancy. Certain drugs act as a teratogene that cause a birth defect, the anti-abortifacient drug, the anti-emetic drug, the anti-epileptic drug, especially the phenytoin, the digoxin and retinoic acid. Some specific teratogens associated with cleft lip and palate, the rubella virus infection, and taking these drugs during pregnancy, the cortisone, mercaptopurine, methotrexate, and Valium. Also, the alcohol consumption and cigarette smoking are associated with facial clefting. As we said, it follows a multifactorial etiology. It involves more than one factor. If one factor only is present without the other factor, the gene will not manifest itself. What about the predisposing factors? Increased maternal age, the Asians, any factors that decrease the blood supply during a pregnancy, as smoking and alcohol consumption, all these can predispose to the development of facial clefting. Cleft lip and palate could be a part of a syndrome. There are many syndromes found to be associated with cleft lip and palate. You can only memorize one or two of them, like the Down syndrome and the Pierre-Robin syndrome, which are the most common ones. When can we diagnose cleft lip and palate for the first time? Thanks to the developments in radiology, and the development of a 3D ultrasonography of the fetus intrauterine in the third trimester, we could diagnose the cleft lip and palate, as in this case. So, what are the benefits of diagnosing cleft lip and palate intrauterine? It gives a time for the parents to be educated about the baby and how to deal with him. It also gives us a chance to prepare them psychologically and to have a realistic expectations of the coming child. It also gives us opportunity to diagnose other congenital anomalies if the cleft lip and palate is a part of syndrome through the amniotic fluid sampling and many other ways. And in countries where abortion is still legal, it gives the parents the chance to choose whether to continue the pregnancy or to cancel it. Some people say that it is an opportunity for fetal surgery. Fetal surgery means to operate in the fetus intrauterine. It has an advantage of leaving no scar at all because healing in the developing fetus leaves no scar of the wounds. But it has many disadvantages because we have to open the abdominal muscles, open the uterus, open the amniotic membrane, operate in the child, and then to close all these layers until the time of delivery. This is a very risky, could lead to premature labor and many other problems to the child and to the mother. Now, let's understand the problems associated with cleft lip and palate. We can classify them into dental problems, aesthetic problems, hearing and speech problems, and psychological problems. Dental problems. Clefting of the alveolus, which is the bone that carries the teeth, together with clefting of the palate, will lead to a missed teeth, a supernumerary teeth, an ectopic teeth, a small or large teeth. It can also cause an abnormal mouth closure in the form of posterior or anterior crossbite, a deep bite, protrusion of the premaxilla. The aesthetic problems. It causes a severe facial disfigurement due to the cleft of the lip and the cleft of the nose. Hearing and speech problems are caused by the cleft of the soft palate. The lost function of the tensor villi palatini muscle, which open the Eustachian tube, will cause a middle ear problem, middle ear infection, which will affect hearing in the children. If the hearing affected is not corrected, then it will lead to speech problems in the future. Also, clefting of the levator villi palatini muscle and lost the function of the soft palate to close the nasopharyngeal sphincter, the velopharyngeal sphincter, will lead to speech problems in the form of hyponasality, as we said also before. These speech problems, if not corrected as early as possible, will lead to a permanent abnormality of speech. Even in some cases, after repairing the cleft palate, the palate might become short, or the muscles might be inappropriately oriented, leading to the persistence of the velopharyngeal insufficiency, which will require a separate operation. The patient is under continuous psychological stress. Timing of management. From the birth to 1 month, it is the initial assessment and to educate the patient about the child feeding and using pre-surgical orthopedics, which facilitate the surgery. At the age of the 3 months, it is the time for the lip repair. From 9 to 18 months, it is a time for palatal repair. At 2 years, we assess the speech and may require repairing the velopharyngeal sphincter. At 9 years, we prepare the patient for repairing the cleft alveolus. At 10 years, it is a time for the alveolar bone grafting to repair the cleft alveolus. The nasal repair at 16 years old, the definitive rhinoplasty for correcting the nose. At 17 to 20 years after completion of bony growth, we might do the orthognathic surgery to the patients with abnormal mouth closure. After diagnosing facial clefting at birth or even before birth, the parents should be prepared well to face this problem. They should understand that it is not their fault that this problem happened, and nothing could be done to prevent this problem earlier. They should be taught well about the management of this problem regarding the surgery, timing of surgery, the dentistry, the speech problems, the feeding problems, and everything. Sometimes it's very helpful to show the parents a photo of a celebrity or a model who had a cleft lip in the past and now he is continuing his life successfully. This one here is Joaquin Phoenix, an Oscar-winning actor, and he had a cleft lip when he was a child. It didn't prevent him from progressing his life from going on. After this, you educate the parents that their child will need a multi-speciality approach consisting of a plastic surgeon to repair the clefts, a speech therapist who will assess and try to repair the speech errors, an audiologist, and an orthodontist to repair the dental problems. Finally, we will talk about the management. The management is divided into non-surgical management and surgical management. The non-surgical management is what to do regarding the feeding and before the time of surgery. These children will have feeding difficulties, so special bottles were designed for them, like the Heberman feeder, which is the most famous one used. We can also use an obturator to close these defects until the time of surgery. It is made from the acrylic, which is a non-adherent substance, and it is molded to meet the child defect. Pre-surgical orthopedics are devices that are fixated to both sides of the cleft with a valve. The parents use these valves to approximate the two edges on a daily basis. It helps the surgery by bringing the two edges of the defect more closely together. The surgical management of cleft lip and palate includes many types of operations, but as an undergraduate student you need only to know one operation for each type of surgery. Let's start by the cleft lip repair. The aim in repairing the cleft lip is to reposition the aloe of the nose, restore the floor of the nose, lengthen the columella, restoring the continuity of the orbicularis oculi muscle, reconstitute the filtral colon. Some of the surgical techniques used are the straight line repair, the use of quadrangular flap, the use of triangular flap, also known as the Tennyson and Rundell, and the use of rotation advancement flap, the Millard flap. The first two operations are rarely used nowadays due to a poor aesthetic outcome. The triangular flap and the rotation advancement flap are the most common used operations today. For you, the Millard rotation advancement flap is the most important one. Here, the triangular flap, the Tennyson-Rundell flap, he opened the defect in the shape of triangle like this, and he straightened it like this to close the defect. The Millard rotation advancement flap, the most common used operation worldwide to repair the cleft lip, is as follows. At first, it's called a rotation advancement flap. This means that we have a rotation flap from the non-cleft side, and an advancement flap from here, from the cleft side. This is called the rotation flap. If we incise here, following this line, and then rotate this part of tissue downward, like this here, it's called the rotation flap. This is the first flap. We also can incise the tissue here and then advance it to meet the opposite side, so it's called the advancement flap, which is here, the advancement flap. The part of tissue between them, this is called the columella flap, which rotated upward to close the columella, to close the nasal floor and may be used to lengthen the columella. It's called the columella flap, and this is the final line of a scar formed. Again, this is an illustration showing us the rotation advancement flap, also known as the Millardi flap. This incision line will form the rotation flap, which is rotated downward. This is symbolized in the R letter. Here, this incision forms the A, the advancement flap, which is advanced to meet the opposite side here, the advancement flap, and the C, this tissue, is called the columella flap, which is used to repair the nasal floor or lengthen the columella. And this is the final line of the scar formed. The following video will show us the marking and the basic steps in the malar rotation advancement flap. At first, we start by marking. A good marking is an indicator of good surgery. We should make sure we have an equal distance between the oral commissure and both the filtral colons, Cupid's bow, and we should make sure that all markings are equal on both sides.
Common technique for cleft. Points 1 are the edge of the lip commissure on both sides.
Here we
Points
mark
2 and 4 mark the lateral edges of the
point
Cupid's
1,
bow.
both oral commissures on both sides, and point 2 and
Point
4,
3 is the midpoint of the Cupid's
filtral
bow.
colon, the edges of the Cupid's bow.
Points 7 are
And
the
then
lateral
the peak of the
aspect of the
Cupid's
lateral
bow,
nasal
point 3.
ala.
Then we mark the ala
Point
of the
5
nose.
is placed such that the distance between points 7 and 5
Then
is
point 5
equidistant
to make
to the
sure
length
that
between 7 and
it's
2.
equal from the ala and equal from the oral commissure. From point
The
1 to 2
distance
is
between
equal
1
to
and 2
point 1
and 1
5.
and 5 should be approximately equivalent.
All this just to make sure that we have an
Point
aesthetic
8
outcome.
is made 3/5
Asymmetry
of the
to both
distance
sides.
across the columella.
Point 2 to mark
Point
the
6 is
columella.
the most superior and medial aspect of the lip skin available.
And the point
Point
6 to
9 is
start
variable
the
depending on
advancement
how
flap
much
from it.
additional length is needed to drop the lip down for aligned closure.
Point 9
Keep
is
in
the
mind
end
that
of
the
the incision
distance
that
connecting
will
4,
form
8,
the
and 9
rotation
is
flap.
slightly longer than 5 and 6, as the rotation flap never unfurls perfectly straight. In this animation, you will see that the M and L lip flaps being discarded, though
The
in
M and
actuality,
L
these
here
will be
mark
used to
for the
help with
parts of the
mucosal
mucosa
lining
that will
during
be
closure.
discarded to correct the
The red lines
orbicularity
drawn
of the
here
muscle
denote
under
the
them.
planned incisions based on these markings.
These lines are the lines for the
The
incision
back
we will
cut
make.
along the columella is variable depending on how much
First, we
additional
start
length is
here
needed
on
to
the
drop
right
the
side.
lip
We
down
see
for
the rotation
aligned and
flap,
symmetric
and on the
closure.
left side we show the advancement
Once
flap.
the skin incisions have been made and the skin flaps undermined,
The
the
discarded
orbicularis
mucosa are
muscle is
removed.
detached on both sides from
The
the nasal
orbicularis
sill
oculi
region.
muscle, which oriented vertically, are
Once
now
freed, the
transposed
muscle
to
layers
be
are
horizontally.
carefully and precisely closed with special emphasis along the
First,
white
we
roll.
repair the muscle, and then we repair the
The lateral
skin
cleft
and the
side
vermilion.
flap is an advancement flap, while
Here
the
the rotation
medial
flap, the
non-cleft
advancement
side is
flap, and the
effectively a
columella flap.
rotational flap.
And this is the scar that will result. Bilateral cleft lip repair. The problem with bilateral cleft lip is that the prolapbium does not have any muscle. So the question is, will the muscle came from each two sides, discarding the prolapbium like it is not present, like the first technique here, the Miller technique, which elevate the prolapbium superiorly and uses the two lateral elements, the two lateral lips, to repair the muscle and to repair the white line, the white roll, like the prolapbium does not exist to repair the muscle and to white roll. But this case is limited if we have a white cleft between the two, between the prolapbium and the lateral edges. We can't use Millard, so the modified Manchester repair, which repair the muscle under the prolapbium and then uses the prolapbium as a cover. So the white roll here came from the prolapbium. And these illustrations show the two techniques. The first technique here is the Millard technique, which which elevated the prolapbium superiorly and used tissue from both the lateral lip elements to repair the muscle and to repair the white line. But here in a white defect we used the modified Manchester technique, which elevated the prolapbium here and then repair the muscle under it and then get the prolapbium back, which is here, to repair the white roll and the other parts. The surgical repair of the cleft palate also has many different techniques. The most common one is the von Langenbeck repair, which is shown here in this illustration. First we create incisions in the midline here, and then we create incisions laterally on both sides here. Then we dissect these tissue under the periosteum to create a mucoperiosteal flaps on the right side and on the left side. These flaps are connected to the bone anteriorly and posteriorly, so they are called a bipedicled flap because they have a posterior pedicle and an anterior pedicle. They are not completely separated, they are only separated from both sides. This dissection under the periosteum will give us a free movement to move them medially to repair first the mucosa, then the muscle, and then the oral mucosa, to be like this. This defect left after the mobilization of the flap is healed by secondary intention. This photo shows the operation. We start by making an incision here and then incision laterally, and then we move the two flaps medially to close the defect in the midline, and the lateral parts here are left to heal by secondary intention. The following video will show us the steps of the cleft palate repair.
Palatal closure operations are layer technique. The operation is carried out under a general anesthetic. The mouth is kept open using special instruments so that the surgeon can concentrate on the operation at hand.
Here we start
First,
by
the nasal floor mucosa is
and
closed.
we repair the
You can see how the mucosa is mobilized. The suture is then put in place and the first layer, the nasal floor,
and
is
then we
closed.
create a bilateral.
The video now
incision,
demonstrates how the palatal mucosa is mobilized
and then
using
we
the two
elevate it
outer
under
incisions,
the periosteum
allowing
to
the gum
create a
flaps to be easily
mucoperiosteal
moved
flap,
toward
which
each
is
other
bipedically
and then
connected
closed,
anteriorly
tension-free,
and posteriorly.
over the cleft. The so-called outer relief incisions are placed above the healthy bone, and mucosa rapidly develops over the exposed bone. You can see that the operation is relatively quick. A multidisciplinary team is important.
Techniques used for cleft palate repair is the Vo-Verdel pushback repair. The Vo-Verdel pushback repair is the same as the von Langenbeck repair, except that we divide the anterior pedicle of the flap. As we see here, we created the midline incision. The two lateral incisions continue to the midline. And then we elevate the flaps, which are now unipedicled, based only on the posterior pedicle. They are the two flaps. It gives us a greater range of movement to close a wide defect, as you see here, and this is the final scar formed. Here with the operation, we divide the flap to include the anterior part also, together with the lateral and the central part, to move it more and more. Another way of repairing the cleft palate is called the Fairlow double opposing Z-plasty. We create a double Z-plasty, one in the oral layer and one on the nasal layer, and then we transpose the flaps and to repair the muscle and to repair the mucosa, and this is the final scar formed. This shows us the Fairlow double opposing Z-plasty. The post-operative care is as important as the operation itself. We are operating on the hard palate and on the pharynx. If any edema developed after the operation, this will compromise the child's breathing, so he should be monitored accurately. The second problem is feeding. This child should be fed in a special way that includes him not entering his finger or a bottle or anything inside the mouth, not to disrupt the sutures. The Third problem, like any other surgery, is the bleeding after the operation that might obstruct the airway. The surgical complications of cleft palate, the bleeding, which if happened will lead to a major complication, and fistula and velopharyngeal incompetence. The fistula. Fistula is a connection between two cavities, here the oral cavity and the nasal cavity. It results from abnormally repaired cleft palate, disruption of the sutures of repair, or ischemia or necrosis of the flaps. Fistula, if developed after cleft palate repair, is a major problem because it will lead to regurgitation of fluids from the mouth to the nose. It will also lead to hyponasality of speech due to escape of air from the mouth to the nose. Repairing the fistula is also a difficult problem. We might use very aggressive maneuvers like the tongue flap. As we say here, we use a part of tissue of the tongue to repair the fistula, fixating the tongue to the floor of the mouth for at least 3 weeks before separation of the flap and repairing the fistula. The velopharyngeal incompetence, it is also a major problem that happens after repairing the cleft palate. It results from inadequately repaired muscle of the soft palate or a short palate due to the contracture after the cleft palate repair. If happened, it will lead to a hyponasality of speech that will require other operations to correct the child's speech. At the end, we thank you all, and if you have any questions, please do not hesitate to contact us.